Thank you. It is a real pleasure to be able to speak to this outstanding group here, and I think it's nice they decided for a little bit of comic relief after lunch to have a academic breast cancer physician get up and talk about reimbursement with economists and health insurance providers and private practitioners in the room. So this just gives you all a chance to say, well, that you don't have that right. And all right. So, but some definitions. I was asked to speak about differences between generics and branded drugs, and so I decided to call this a little bit tongue-in-cheek, you get what you pay for, and to get into the unintended consequence of buy and bill in oncology. Some brief definitions familiar to all of you are that branded drugs are, of course, novel drugs approved by the FDA, usually, to use Dr. Conti's words, produced by a pioneer manufacturer. They have exclusive production for patent duration, as you saw recently in Dr. Bastian's talk, Alex Bastian's talk. So generic drugs, of course, are the drugs that are approved following application, following patent expiration. They can theoretically be made by multiple manufacturers, and you just have to show that they have the same active ingredient, bioequivalence, strict production standards, and then they can be brought to market, hopefully cheaper, but of course, as we get into biosimilars, that's not entirely clear. Now, let's reflect on the societal goals we have here, and I think all of us share these. We want to incentivize new drug development. That's come up a number of times this morning. The theme of the whole day is trying to guarantee patient access to beneficial therapy, but it's easy to lose that sight of that overarching goal as we get into the weeds in some of these issues. And then I think we can all agree that we'd like to save money through use of generic drugs when that's possible and appropriate. And to do that, we need to, as you've heard already this morning, to incentivize manufacturers of generics, encourage patient and physician use of generics, which is a little bit of a separate issue, and of course, avoid disincentives to use of generics, which I'm going to talk a little bit about. So I'm a clinician. How should medical decisions be made? What did I learn in medical school? Well, we want to base them on efficacy, safety, patient preference, shared decision-making, and the quality of life impact. And you put all these together, and you hopefully get high-quality, patient-centered care. This matches very well. I also study bioethics, and this matches very well with those core bioethical principles like beneficence matches with efficacy, autonomy is where we bring in patient preference, non-maleficence, focusing on safety and the principle of doing no harm and avoiding toxicity. And then this principle of justice also that underpins some of our conversation today, looking at efficiency and equity. So I think this is fair game from the clinician's standpoint. And I just want to start with a case which reflects on the value of innovation. A 45-year-old woman who could easily, this is a hypothetical case, but this happens all the time in my practice, comes in with HER2-positive metastatic breast cancer. She was previously treated in the adjuvant setting with adriamycin cytoxan. The guidelines would tell us all that we want to pick one of the HER2-targeted therapies for metastatic disease. And the question comes up in this first-line setting, do we use this novel drug, pertuzumab? The data we have is that there's been a phase 3 trial with more than 800 patients, a large randomized trial. They were randomized to trastuzumab plus taxane, a very effective regimen that we've relied on in recent years, or that combination plus this novel drug. And it turns out that adding the novel drug, another antibody and an expensive one, improves progression-free survival by 6 months. And we can't really talk about overall survival because we haven't even reached the median yet in the experimental arm. But we can say things like, for overall survival, your chance of being alive, if you're on this pathway, the red one with pertuzumab, is 66%, 2/3, versus 50%, which I think if any of us had the choice for ourselves or our loved ones, we would rather be on the red arm. There's no question. So this is an example where almost regardless of cost, although it's not irrelevant, we would all choose that top line and try to get this drug. Now, cost is not irrelevant to the discussion. Trastuzumab and docetaxel, although arguably you could use a different taxane, estimates a few years ago showed that it's about $124,000 for the regimen. Pertuzumab, if you're on it for a year in the metastatic setting, would add about $71,000. So your total cost of this regimen for a year would be $195,000. And I do think that if we all decide this is important, and as Alex showed us, maybe this isn't paying too much for cancer care. Maybe we need to put this forward and say, we need to invest more, but we definitely need to find a way to make this sustainable and pay for it so that everyone has access to it. There's no question. So this is sort of how medical decisions need to be made 2.0. All of the things I mentioned before, and I'm also bringing in, as Dr. Zafar and others have mentioned, cost to the patient and cost to society, which is a distinct but equally important issue. And perhaps These don't all need to be weighted exactly equally. When we make a decision, we want to think a lot about efficacy. We want to think about safety and the quality of life impact. Also these other factors, and that gets us to value. So now another case. This patient has, again, a 45-year-old with metastatic disease who has triple negative breast cancer. She also was treated in the adjuvant setting with adriamycin Cytoxan. And the guidelines would tell you that we now want to pursue taxane-based chemotherapy. So the question would come up in my practice, am I going to use generic paclitaxel or Taxol or nab-paclitaxel called Abraxane? Well, what's the data? We have a 2005 randomized trial comparing these two interventions showing that Abraxane is superior. There was an improved response rate, 33 versus 19%, improved time to progression, although we always get nervous when it's measured in weeks, 23 versus 19. There was no survival benefit, but Q3-week nab-paclitaxel was better than Q3-week paclitaxel. Okay, so you may say on the basis of efficacy and safety, which was good, that you'd use that. Now, we've got to bring in this 2008 trial that I'm aware of, where we have just switching the regimen of paclitaxel, good old generic paclitaxel, from Q3-week versus weekly, we get comparable benefits. You know, can't compare perfectly trial to trial, but you get a benefit in terms of improved response rate. You get time to progression benefit, now measured in months, and improved survival. So weekly paclitaxel would be the standard I'd measure it against. And we have this 2012 trial, which included other things like adding bevacizumab. But if you just, fair or not, if you distill down the Abraxane versus paclitaxel regimens, and there's questions about the dosing, and I'm not here entirely to support or defend this trial, but the bottom line is the yellow is the generic paclitaxel. It's certainly not inferior to the nab-paclitaxel. I've told you this is the comparative regimen. So I don't have a lot of efficacy reasons to prefer the novel branded drug against the generic. So all of us could decide, which one do you want to choose? Paclitaxel is generally well tolerated, does come with a higher risk of allergic reaction, higher risk of neutropenia. Nab-paclitaxel also very well tolerated, has a quicker infusion time, and a higher risk of neuropathy. You might weigh those things against each other, and then I say, well, this one's generic, and this one's on patent through 2024. So let me just ask by show of hands, who would choose the paclitaxel based on what I've showed you so far? You don't have to be a physician or patient to vote? Okay. And would anybody choose the nab-paclitaxel based on what I've shown you so far? So not everyone's voting, but everyone who voted picked the paclitaxel. Now, what if I throw in, and of course there's social desirability is something we talk about when we do surveys, so I won't ask you that question again, but I throw in the fact this is about $312 a dose, depending on which estimate you looked at. This is close to $6,000 a dose. So if you look at a 6-month course of treatment, it's $5,600, and this is $46,000. So by show of hands, would anyone change their mind now? Anybody now want to give the nab-paclitaxel? Okay, that's the social desirability phenomenon I'm talking about there. And unfortunately, and this is the main theme of my talk, what if you were reimbursed at AWP plus 6%? And the impact is that generic, you'd get reimbursed for the cost of the drug, plus a nice $336 to keep your practice running, pay the nurses, maybe pay the nutritionist and do some of those other important things. The Abraxane, you would pocket almost $3,000 for all of those things. And you're going to roll it right back into patient care. Then, arguably, it becomes a little bit more challenging. So this is the big question for all of you. And this is a bit of an optical illusion I've created here. So don't help your neighbor. Which of these is bigger? Right. Okay, it's tricky, huh? This one's bigger. And so unfortunately, in practice, we know that medical decisions are sometimes, at least arguably, are made with all of the above. And I think we have to be crystal clear that none of us went to medical school to focus just on this. And I really don't believe, I guess I'd hope I don't have evidence, but I think that this comes in for all oncologists when they're seeing patients. And everyone who's an oncologist has family members who are affected and has affected themselves by disease and illness at some point also. But financial incentives matter. So how did we get here where we might have these perverse financial incentives? So pre-1998, we always talk about 1998 and on, pre-1998, practices are getting reimbursed essentially for 100% of the price of the drug. But of course, the drug may list here, you'd get a bulk sale discount, often much more than this. Sometimes there's a 6-fold difference between these things. Reimbursement then would be $1,000, and you'd get this margin. And as I showed, we can all imagine that that does, on some level, particularly when there may be equivalence and you're not harming the patient anyway, that influences practice, we think. Now, after the Balanced Budget Act of 1997, it was reduced, so we saved a ton of money by dropping it from 100% to 95%, but of course that continued the same thing, just with a slightly smaller margin. So then this beloved Medicare Prescription Drug and Modernization Act came along in 2003. The goal, of course, was to better align reimbursement with the purchase price plus the administration cost. That is the stated goal. No one was trying to hurt practices, certainly not trying to hurt patients or access. But it became ASP plus 6%, as you've already heard today. And of course, with the sequester, it's become plus 4.3%. So it did, by some reports, the MedPAC report, save money up to $800 million in that first year. But it unfortunately still incentivizes the use of more expensive drugs. And as you've heard already today, it puts many, if not all, practices underwater. So practices not getting a discount, ASP, if this practice in general is not getting the discount, so the sales price takes into account discounts that are going on around the country, but your practice isn't involved in that, you're out of luck. The ASP is not kept up to date, and there can be huge swings. Patients may not be able to pay for copays, and that can hurt the practice and leave uncompensated care. And the administration costs are not adequately covered. There's lots of things that you have to do to give a dangerous chemotherapy agent, monitoring the after effects of that. So when we look back at the societal goals that I think we all agreed on, we are incentivizing new drug development currently. I'm not sure we're guaranteeing at least convenient and community-based patient access to beneficial therapy as much anymore. And we're also not saving the money we might through use of generic drugs when possible. So I've raised the question, do financial incentives impact oncology practice? We have a little bit of data, but it's very hard to get good data in this area, and that's probably the one caution I'd throw to this. So Jacobson's published a series of nice papers. One of the more recent ones was in Health Affairs in 2010, and you see here the drop-off in reimbursement for some of these drugs as their patents expire. And Dr. Conti has shown in her work the really steep patent cliff you can face with things like topotecan and other drugs. Once the patent expires, you can have a 90% reduction in the cost. So practices are making less. And what Jacobson and colleagues showed is that, related or not, tracing it around to that time in 2005, when these drugs go off patent, you see chemo use. So what can an oncologist do? They can do two things. They can shift to more expensive drugs, and they can simply give more chemo to defend revenue. Now, look, there could be other things going on in the lung cancer world at that time that mean, there's evidence like we just saw out of ASCO for prostate cancer that people should be getting more chemo. That's not well taken into account in this, but you do see this increase in chemo, and when they looked at the data for a shift from generic paclitaxel to docetaxel, they found it, as you'd expect, with some degree of shifting to compensate for the loss in reimbursement revenue, probably. And similarly, sorry for misspelling, I'm not a GI oncologist, but in Dr. Conti's work, she showed a similar 18% decline in the use of irinotecan versus oxaliplatin following irinotecan going generic in 2008. It shows you largely the same thing. So why is this? Is greed the only factor at work here? It's a very appealing picture. Certainly we'd like to hope not. And there is some countervening evidence that at least needs to be put in the equation before we just decide that it's all the greedy oncologist's fault for the problems we face here. This was an experiment published recently in American Journal of Managed Care by Dr. Feinberg and colleagues, where they looked at a oncology medical home pathway program. And basically, as you can see in the figure, they shifted money largely from drug reimbursement codes to professional charges, trying to reward oncologists for the cognitive services that we should be delivering. What they found was that they didn't really see the change in MD behavior you might have expected. They didn't notice any difference in the delivery, the type, or the frequency of chemotherapy. They didn't find either more or less use of generics over the time period. And they actually didn't see any increase. They didn't see, okay, now you're paying me to see patients and talk to them, so I'm going to do that a lot more. That didn't change. So what they argue in effect is not that this is the whole answer, but that at least we need some caution in deciding that all of oncology practice is based solely on these financial incentives, and we'll shift back and forth as we change the dollar signs. We'd certainly like to hope not. And further, this came out of, I think, the ASCO Clinical Practice Committee, as well as the Community Oncology Alliance, these principles to guide the evolution, as everyone recognizes that some kind of reimbursement reform is needed, and no one is really standing up to defend buy and bill right now, but arguing that there's the reimbursement models we have right now provide inadequate support for care coordination, complex disease management that is really required for high quality cancer care, essentially saying, listen, take it from the patients also, but we who have the experience of being with a large volume of patients can tell you that you're giving something up if you don't pay for this care. And we don't know how to say it any louder. And that ASP plus 6 is really inadequate. You saw the data on practices going underwater and merging, which may or may not be good for patients. That ASP plus 6 is inadequate to cover costs and the risk for purchasing and maintaining expensive cancer drugs. Even if you think of the float that's required, and this again came up in, I think it was Dr. Gould's talk earlier, about the fact that you need to keep 1 million plus of inventory. How can a small practice do that? And I don't think the intent of ASP plus 6 was to drive practices out of business. This is just a partial list of all the other things that are done that we know are under reimbursed in oncology care. And many of us in this room, in other forums and other panels, have argued that these are very important. Even taking the time to adequately discuss the costs of care for our patients, survivorship care planning, navigation, palliative care, shared decision-making, in all aspects of care, symptom management, palliative care, patient education, et cetera. Also, and I'll just say a little bit about this, you heard about this earlier, there have been, I think, unintended consequences of this. By establishing ASP plus 6, you essentially blunt the normal response you'd have when there are drug shortages, and as you heard, you disincentivize manufacturers to go into this space. So unless, one solution I did not hear was having the government or some other agency step in and develop generic drugs. I mean, maybe that should be on the table. But short of that, we need to incentivize manufacturers in the private sector. And so this seems to be a problem there too. And Dr. Emanuel in his New York Times article just cited the data that in 2004, right before this kicked in, there were 58 new drug shortages reported in addition to existing drugs. This kicks in, related or not. A few years later, there's 211 drug shortages, many of them in oncology generic drugs. And when you get to biosimilars, which is really not the focus of this talk or of my expertise, the question is, will we get cost savings as our biologicals, our antibodies, our immunotherapy patents expire? We all want these things developed, brought to market. I think we're okay with incentivizing the development of them, but then ultimately we'd like the prices to come down. But as you see there from this article in Clinical Oncology News, sorry, it's a little bit blurry, our small molecule generics are expensive enough, 1 to 2 million to make over 3 years. It may take 3 times longer and cost 20 times as much, 40 million, which can be as much as it takes to bring a new drug to market. So there's going to be less competition for sure, and it's unclear if there will be savings from these very important drugs. As again, as Alex said, if you could just address that problem for things like rituximab and trastuzumab, maybe we don't have the rest of this conversation. So what are some of the solutions that have been proposed? Well, we could find a way to pay more for generic drugs. Again, Dr. Emanuel proposed, ASP plus 30 for generics. I don't think anybody's jumped on that yet, but maybe they will. Obviously, we could pay more for the chemo administration fee. I mean, really, why should that be lumped in? The administration fee really is independent from the price of the drug. Maybe a new drug, you got to get used to it or get used to the toxicities, but it's hard to imagine that it should swing widely from drug to drug. So that doesn't make a lot of sense to build that in to the reimbursement. And dealing with the expenses for floating the cost of the drug and inventory is a separate issue. We could, as you may hear more from Dr. Newcomer, we could pay for what the oncologist actually does. That's what that study I showed you, it was trying to do, paying for symptom management, cognitive aspects of care. And Lee wrote an excellent article in JOP just recently talking about some of the options in this area and some of the challenges, both with doing the research and with establishing these models, pay for performance, bundled payments, capitation, which still exists in some areas. And I don't know if he's going to talk about it now, but as mentioned, particularly in our conference call on this, that there's a reimbursement pilot program to try to incentivize use of generic drugs. But the problems that come up is it's not universal. So I'm a doc in clinic. I got patients with 20 different payers, or at least 10 different payers. I don't necessarily know who's in which program or not, and I may not have the time to spend on that. So the impact that one payer's program can have is definitely limited, and certainly in many practices, Medicare dominates the market. So if people are going to follow what the Medicare reimbursement is doing. And then finally, we could pay less for branded drugs, and I think we had at least the beginning of a nice conversation about this already. I put this up because I know it's Yusuf's favorite slide. As we have the epic battle between healthcare costs and innovation, with the doctor and paper struck in the middle. As we all know, in Europe and other parts of the world, they're very concerned and they're kind of fans of Godzilla, but King Kong's our guy, right? So in the US, we know who we're backing here. So we need to replace buy and bill. We know, I don't think there's going to be a defender of it in this in this room. It's irrational. It's essentially unsustainable. But forgive me if I'm a bit of a cynic, and outside of pilot programs, I'm really worried when I see what's going on with reimbursement, particularly at the level of the government, that we're just not going to forget adequately. We're not going to compensate those other important aspects of care unless we make a lot of noise. It's very easy to roll it back and say, hey, we're paying too much for prescription drugs, and I think on some levels we are, but I'm not sure how we can best articulate the argument that we need to pay for these other things. So that's my concern, and I'm sure it will hurt my patients as well as, of course, some of my colleagues. And so in the end, as I started, I think you get what you pay for. And if you incentivize doctors to give a more expensive drug, particularly against a generic, you're going to get use of more expensive drugs. Big surprise. And you'll get higher spending. So we need to deal with that. And we also need to figure out a way to pay for and support innovation in patient-centered, community-based cancer care. Finding the balance is the key between rational payment reform and high-value care. Thank you.
Now we'll have the talk on oral versus IV drugs. Dr. Newcomer needs no introduction.